Good morning, everybody. Thank you. Thank you, sir, for the introduction. Thanks to Dr. Lalit, sir, and Dr. Sandeep for this conference. So what you can... So in the next 15 minutes, I thought what I would share with you is what we think are the advances in the last 1 to 2 years in the field of metastatic colorectal cancers, especially. And because we know that several things have happened, and then I wanted to share and see what all have been notified and then published in the literature. So if we look at the biomarkers, the idea of the theme of this conference is to look into the biomarkers and then the precision medicine. So what are the ways in which we can precisely treat our colorectal cancer patients? When we think of biomarkers in colorectal cancers, all these things do run in our minds. First, do we apply this precision medicine in adjuvant setting or not? If in metastatic setting, we should there be in the first line or should it be in the second line? And what about the testing of RAS, microsatellite instability, the NTRK, RET, HER2, the PIK3, BRAF, MET, exon, tumor mutation burden, so on and so forth. There are many things which we keep coming to our mind, and then let us see the status of each one of these as on today. It may change tomorrow because the science is so rapidly evolving. And we also know that colorectal cancer is a very heterogeneous kind of a cancer, and then it's a very dynamic thing. What happens today may not remain when the metastasis happens, and when the progression happens, things may keep changing, is what is known, and that is the reason why the circulating tumor DNA is being becoming very more and more popular, especially in the field of colorectal cancers. So when we look at precision medicine or personalizing the therapy in the adjuvant setting, what we can think of as on today is only one place, that is in the stage 2 colorectal cancer, whether to give somebody a chemotherapy or not. Yes, so we do look into that, whether the microsatellite instability is there, the deficient mismatch repair status is present or not. If it is there in stage 2, then we can safely ignore any adjuvant treatment and then follow up the patients. So as on today, for the adjuvant therapy setting, except for this knowing the status of MSI, there is not much in terms of personalizing the care in these kind of patients. The rest of the discussion is for metastatic setting. This is a very beautiful article which was published in 2018 in the ASCO educational book. This speaks about the landscape of molecular changes or the genetic changes which occurs in metastatic colorectal cancer specifically. So if we see that it is projected that about only 25%, only 26% of all the patients with metastatic colorectal cancers are wild type. And we know all these mutations and all these alterations do occur in these patients. For instance, we see this RAS mutation, KRAS, NRAS, HRAS mutations. They account for up to 45% of all the mutations in these patients. PIK3, PTEN mutations, BRAF, V600E, and then the MSI positive things where we use the anti-PD1 or anti-PDL1, and HER2 amplifications, the MET amplifications, etc. So this is largely described. What we now want to know is where exactly in the treatment algorithm, where do we incorporate all the knowledge, whatever we are getting. So that is what the crux of this the whole discussion is about. At the same time, this is the genomic markers, and there is another transcriptomic markers. So what is the difference between genomic and transcriptomic? Transcriptomic markers are especially based depending on the RNA based testing, whereas genomic markers on the DNA and specific mutation or fusion based testing is done. But the RNA based targeted treatment is, of course, it is in development, and they have proposed the consensus molecular subtypes of colorectal cancers, which is not yet taken off in clinical practice. In clinical practice, what we know is these things can be tested, and then let us see what we have in the record, on the record. So first thing first, all of us nowadays are testing in clinic, especially for colorectal cancer patients, the microsatellite instability or the deficient mismatch repair system. And we know that when a patient comes with a metastatic colorectal cancer with the mismatch repair, the first line treatment, pembrolizumab, is known to increase the PFS and also the overall survival from the Keynote 117 study. Pembrolizumab versus chemotherapy in good 300 patients, we could establish the median progression-free survival with pembrolizumab is 16.5 months as to 8.2 months. In this way, we can precisely select the patients who are candidates for the pembrolizumab or the immune checkpoint inhibitors. But what is important is what happens in the first 6 months of treatment. In the first 6 months of treatment, as we know, as with the immunotherapy in all subtypes of cancer, we know that those who respond, they respond really well. But those who do not respond, we should be very careful in the first 6 months, monitor them very frequently. And the moment we know that they are not responding, we should quickly able to change to some other treatment. And the beauty of the immune checkpoint inhibitors, wherever we apply this precision medicine, is that the response rates continue to be 83% at 2 years, which is not that common in metastatic colorectal cancers. And if you look at the subtypes, almost everybody seems to be benefited from the immune checkpoint inhibitors once the MSI is established, except in this population, which is a KRAS mutant. We know that KRAS mutant in general is a poor prognostic sign, and they should be very careful in offering this kind of treatment for KRAS mutant patients, and we should be very watchful of them. The next other immune checkpoint inhibitor which has been made its mark is the nivolumab or ipi-nivo combination. This is the Checkmate 142 trial. We have seen this has been presented in the recent ASCO. What I'm interested in is to look at the cohort 3. Cohort 3 is the patients who are treatment naive, no prior therapy for metastatic disease. If microsatellite instability is noted, then probably nivolumab ipilimumab combination is going to be the first line recommendation in near future. Sorry. So this is the updated analysis at about 4 years, 47.6 months is 4 years. We see that the cohort 3, which I am looking at, that is the first line treatment of ipi-nivo combination, at 4 years, the median survival is not reached, which means that it is possible to precisely identify patients who are candidates for immune checkpoint inhibitors and then deliver them this kind of treatment. The other important point which we would be failing if we don't mention, because this molecule made a lot of news in newspapers rather than medical journals, is this dostarlimab. Dostarlimab is the PD-1 blockade in mismatch repair deficient, locally advanced rectal cancers. The design itself was different because they were looking at the pathological, the clinical complete response rates, and give this treatment and then don't do anything for those patients, no chemotherapy, no radiation, which is, in fact, it is not up to the mark, or it doesn't, all of us are not comfortable with in doing this, except in a clinical trial. But however, dostarlimab, we cannot ignore this, because in all the 12 patients who were given, at the end of 6 cycles, they had a complete clinical response. And of course, the long-term follow-up is awaited. This is not for clinical application as of now. The other things which we discussed previously is the RAS and BRAF mutations. The more and more we are looking into the next generation sequencing. That's what at least we are doing it in our institution. We are trying to run the at least limited panel of next generation sequencing, which includes the FGFR, KRAS, NRAS, HRAS, and then things like the HER2. The RAS mutations, what do we know? When somebody is having RAS mutation, we know that EGFR antibodies are not going to work, and we are not going to give them. So it is a negative predictive marker for EGFR-based therapy. But this is the trial which has been recently again published this year, ASCO 2022. The paradigm trial, the overall survival, the follow-up of the 5-year follow-up of this study. What we already know has been confirmed by this trial. Whenever we are going to use the anti-EGFR antibodies, especially panitumumab, in left-sided colorectal cancer patients who are KRAS wild type, it is that group of patients who are going to benefit to the maximum in terms of overall survival. Regarding the BRAF mutation status, all of us know that the BRAF mutations itself is a predictive marker for BRAF inhibitors in melanoma and other things, and it has made its mark in colorectal cancer also. So BRAF is the downstream pathway, and BRAF V600E mutations, especially BRAF V6, it's found in about 10% of patients when we run that next generation sequencing. And this is the trial which is called as a Beacon CRC trial. It had, in patients who are first line or after first line, 1 or 2 prior lines of therapy, if a patient is found to have this BRAF V600E mutation, those patients can really do well if we give them binimetinib plus encorafenib plus cetuximab. So encorafenib is a BRAF inhibitor, binimetinib is a MEK inhibitor. So all of us know why we combine these two things. So MEK inhibitor and BRAF inhibitor, when we combine it and when give it along with cetuximab, probably these are the patients who are going to do well, and that is how we can precisely apply our knowledge in treating this kind of patients. But please remember, it is in the first or after 1 or 2 lines. And of course, in this trial, they looked at the overall response rate and the overall survival. And this Beacon CRC has come out with the results mentioning that in patients with BRAF V600E mutation, the combination, either a doublet or a triplet. The triplet is cetuximab, encorafenib, binimetinib, and encorafenib, cetuximab is the doublet. So wherever possible, wherever indicated, try to use this kind of, incorporate this kind of medicines whenever they are available. The other important update, what we got from the recent this thing is the KRAS G12C inhibitors. We already know this kind of mutation in lung cancer. It is now extending into colorectal cancer also. If we do an NGS and find a KRAS G12C inhibitor, sotorasib and adagrasib, these are the two molecules which have been studied in phase 1 and phase 2 studies, either alone or in combination with EGFR antibodies, and they are known to have some activity. Why is it important to know about all these things? Because there are several clinical trials which are going on, and sooner or later, maybe in a year or two, all these may move on to the first line also. The other important is the HER2 amplification in colorectal cancers. We already know much about this HER2 amplification in breast cancer, in lung cancer, and now it's coming on to the colorectal cancer also. HER2 amplification, it is the literature reports up to 5%, 2.5 to 5% by IHC or FISH. And as seniors also would agree, when ALK started, we used to say that ALK in lung cancer is very less. Now in our practice, we are finding ALK so common because we are testing. And in my own practice, compared to last 5 years and then these 5 years, the number of patients whom I'm asking for NGS has increased. The acceptance has also increased from the patient side. So definitely we are going to see much more positive rates, especially in Indian literature sooner or later. And HER2 amplification is known to be enriched in KRAS, NRAS, BRAF, PIK3 wild type tumors. Of course, you select those patients and then test HER2 in them, they may be positive. And then there are at least 4 clinical trials which have tested the anti-HER2 therapies. The My Pathways, it is a basket trial, that meaning a tissue agnostic trial, the Heracles trial, the Mountaineer trial, and the Destiny trial. So all these trials are either phase 1B or phase 1 or phase 2 trials. So in My Pathway, it tested the trastuzumab, pertuzumab in solid tumors. 84 of them were the colorectal cancers. The objective response rate is 26%. And what is important is when HER2 is present, KRAS mutation also may be there. If KRAS is wild type and HER2 is present, they are the correct patients for anti-HER2 therapy. So that is how we can precisely apply this knowledge in second or later lines. When HER2 is present, we should also test for KRAS. If KRAS is wild type, that is the best group of patients to go on this type of drugs. The Heracles study, trastuzumab tested trastuzumab lapatinib, and then the Mountaineer study tested the tucatinib with trastuzumab in HER2 amplified metastatic colorectal cancers. In all these studies, what we understood is that when KRAS is wild type and HER2 is amplified, then they are the candidates for any of these kind of treatments. And as we know, the newer drugs we introduce, the better is the result. Same with the Destiny CRC01 study. And the best chance of tumor regression is when we combine this trastuzumab deruxtecan in these patients. In cohort A, it had 3 cohorts. Cohort A means IHC 3+, cohort B is IHC 2+ FISH positive, cohort C is IHC 1+. And the best patients are, we know, are IHC 3+ patients. The other important update which we got recently is about this NTRK. NTRK is, there is a lot of noise about this NTRK, but the music is yet to be played. And so NTRK fusion in GI cancer is rare, but it is actionable. And it is reported literature is less than 5%. And the good thing, or maybe if we can standardize, we can use IHC in our patients and test whether this is positive or not, because there is a very good correlation between IHC and the NGS and even FISH in the literature. And these are the methods to test. The approved, FDA approved agents, this is tumor agnostic approval is there for larotrectinib and entrectinib. These are the first generation NTRK inhibitors. And then the selitretinib and repotrectinib, these are the newer generations or second generation of NTRK inhibitors, which are known to have good activity. And the objective response rates, as you can see, and all these have been tested in second, third, or later lines of treatment. So the objective response rate is 40 to 70%, meaning that as the time goes by, when they move into the earlier lines of therapy, we expect even better results. And this is my last but one slide. So what is important for us, for me to convey is that even the ESMO guidelines, the latest ESMO guidelines, the article is in press, which says the metastatic colorectal cancer ESMO clinical guidelines for diagnosis and treatment. there is something called as ESMO scale of clinical action
carcinoma are PD-L1 expression, so that remains very important therapeutic target. And the important point is that majority of these esophageal squamous cell carcinoma, they are being seen in the Asian regions. GE junction, we will not touch upon the GE junction and gastric cancers today. If we see the esophageal squamous cell carcinoma, we know about the pathology, and we know that 60%